I'm happy to join medical students in this series of lecture in cardiovascular disease. Our subject today titled as the mitral valve disease and mitral valve regurgitation. Mitral valve regurgitation, either acute presentation, as we said in the previous lecture in myocardial infarction complication, or chronic. In every valvular disease, our objective is to know etiology and pathophysiology behind hemodynamic change and what the finding during clinical examination of the natural history of this disease, how to diagnose and how to treat, what's the prognosis. The most common cause is aromatic heart disease, about 50% in developing countries. While in the Western nation, the mitral valve prolapse is the most common cause of mitral regurgitation. Other causes of the mitral regurgitation include aortic valve disease, acute rheumatic fever, myocarditis, dilated cardiomyopathy, hypertensive heart disease, ischemic heart disease, infective endocarditis, hypertrophic cardiomyopathy, if you remember in a lecture of the hypertrophic cardiomyopathy, SLA, Marfan syndrome, Ehlers-Danlos syndrome, ruptures of the chord tendon, example due to the complication of acute myocardial infarction, usually transmural, usually ST segment elevation MI. In pathophysiology and hemodynamic change, regurgitation into the left atrium produces left atrial dilatation, but little increase in left atrial pressure. So it's a problem of volume overload, not a pressure overload as in a mitral stenosis. It's purely is the pressure overload. With acute mitral regurgitation, the left atrial V waves, venous waves, is greatly increased and pulmonary venous pressure rises to produce pulmonary edema. Since proportion of stroke volume is regurgitated, part of the stroke volume is back regurgitated into the left atrium. The stroke volume increase to maintain the forward cardiac output and left ventricle therefore enlarged. And this increase by compensatory mechanisms like enlargement of the left ventricle, tachycardia, and other compensatory mechanisms. Mitral regurgitation can be present for many years before any symptoms occur. The increased stroke volume is sensed by individuals or patients as a palpitation. Dyspnea and orthopnea are major symptoms developed due to the left ventricular failure. Fatigue, lethargy develop because of reduced cardiac output. In a late stage of disease, the symptoms of right heart failure, as we said in the lectures of heart failure, the most common cause of right heart failure is the left side heart failure. So it's heart failure right side also occur and eventually lead to the congestive heart failure, biventricular failure. Cardiac cachexia may develop in chronic heart failure. Thromboembolism, although it's happened, but it's less common than mitral stenosis. But in comparison with pure mitral stenosis, the infective endocarditis is more common. So definition is the backflow of the blood from the left ventricle to the left atrium during systole. Part of stroke volume return back to the left atrium. Mild or physiological mitral regurgitation is common and is seen very common, seen in the echocardiography in about 8% of patients. What's called trivial or the physiological, even normal individuals, especially elderly. The causes of acute mitral regurgitation is the endocarditis, subacute bacterial endocarditis, acute mitral myocardial infarction, as we say, the STEMI, especially anterior wall, and because of transmural necrosis, and malfunctions or disruption of prosthetic valve if the patient already have valve prosthesis. So myocardial infarction, management really, if myocardial infarction, do PCI, as we said, it's mostly STEMI. If not available PCI, we can give thrombolysis. Most other cases of mitral regurgitation is the afterload reduction. They need afterload reductions by diuretics and nitrates, nitroprusside, even in a setting of normal or low blood pressure. So don't attempt to alleviate in acute mitral regurgitation tachycardia with beta blocker. Mild to moderate tachycardia is beneficial in those patients because it's allow less time for the heart to have backfill, which is lower the regurgitant volume. So proper antibiotic is given if indicated to prevent SBE. So most of the patients, they need bridging by the balloon counter pulsation, nitroprusside infusion, even if the normal, as we said, normotensive or hypotensive, then send the patient to the surgical room. While chronic mitral regurgitations, the main causes, as we said, is the MVP, maximatous degeneration mitral valve prolapse. Ischemic heart disease, second most common, myocardial infarction. The third most common is the rheumatic heart fever. But as we said, in developing countries, rheumatic fever is very common. Still about 50% of a chronic mitral regurgitation in developing countries is rheumatic in origin, usually associated with the other valve, not isolated, commonly with aortic valve or mitral valve stenosis. Infective endocarditis as a cause of chronic mitral valve. As we said previously, it can be in acute endocarditis in acute mitral regurgitation. So it is a pure volume overload, mitral regurgitation. Compensatory mechanism, as we said, to increase stroke volume, left atrial enlargement, left ventricular hypertrophy, increased contractility, tachycardia, progressive left atrial dilatation, and right ventricular dysfunction due to the pulmonary hypertension. Progressive left ventricular volume overload lead to the dilatation and progressive heart failure. During auscultation, soft first heart sound and hollow systolic murmur at the apex radiating to the left axilla. S3, third heart sound, congestive heart failure of left atrial overload, left atrium overload. In chronic mitral regurgitation, the intensity of the murmur does correlate with the severity. In contrast to that, the mitral stenosis, the intensity of mid-diastolic rumble not correlated with the severity of mitral stenosis. Exertional dyspnea, exercise intolerance, as the symptoms, heart failure may be consigned with the increased hemodynamic burden, example infection or atrial fibrillation. Uh, in the pregnancy, in general, pregnancy can tolerate better regurgitant valve, either aortic regurgitation or mitral regurgitation, but cannot tolerate well stenosis, like that the mitral stenosis or aortic stenosis, because of increase of plasma volume. The symptoms of mitral regurgitation can be present for many years before any symptoms occur. The increased stroke volume is sensed, as we said previously, as palpitation. Dyspnea and orthopnea develop due to the left ventricular failure. Fatigue and lethargy develop because of reduced cardiac output. In the late stage of the disease, the symptoms of right heart failure also occur and eventually lead to the congestive heart failure. Cardiac cachexia may develop. Thromboembolism, as we said, is less common than mitral stenosis, but subacute infective endocarditis is more common in comparison with the mitral stenosis. Sign during physical examination, laterally displaced, forcible, diffuse epic speed, and a systolic thrill if severe, we can feel it. Soft felt heart sound on auscultation, pansystolic murmur radiating widely over precordium but into the left axilla. Prominent third heart sound if the congestive heart failure or left atrial overload. The sign related to atrial fibrillation, pulmonary hypertension, left and right heart failure develop later in the disease progression. Compensatory phase, as we said, natural history of mitral regurgitation, about 10 to 15 years, asymptomatic. Patient with asymptomatic severe mitral regurgitation have a 5% year mortality rate every year. Once the patient ejection fraction become less than normal, less than 60%, and or become symptomatic, mortality rise sharply. I mean, if asymptomatic with the severe during investigation, even there is a mortality about 5% every year. But if the ejection fraction start to deteriorate and ventricular function start deteriorate, or the patient symptomatic, so mortality is sharply increased. Mortality from progressive dyspnea and heart failure. Investigation, chest x-ray, left atrial and left ventricle enlargement. There is an increase in cardiothoracic ratio, and valve calcification sometimes is seen. Central pulmonary artery enlargement. ECG show the feature of left atrial delay and the left atrial bifid P wave and the left ventricular hypertrophy as manifested by tall R waves in the lead 1 and precordial V6 and deep S wave in the right-sided. Precordial lead, I mean V1 and V2. Atrial fibrillation may be present. Echocardiogram is very essential as in the mitral stenosis. Dilatation of left atrium and left ventricle. There may be specific feature of chordal or papillary muscle rupture in acute, especially in acute. Estimation of left atrium, left ventricular size and function and ejection fraction. Valve structure assessment. Transesophageal echocardiography if a transthoracic echo is inconclusive. Cardiac catheterization, we need it more common than in mitral stenosis if ischemic heart disease or we need a surgery. In the treatment of mild mitral regurgitation, in the absence of symptoms, can be managed conservatively by the following the patient with serial echocardiogram. Prophylaxis against endocarditis is required and prophylaxis against recurrent traumatic fever. Any evidence of progressive cardiac enlargement generally warrant early surgical interventions by either valve repair or replacement. In the patients who are not considered appropriate for surgical intervention, management usually involves treatment with as a heart failure with ACE inhibitors and diuretics and possibly anticoagulation if there is a rhythm abnormalities. Medication used in mitral regurgitation, vasodilators such as hydralazine, rate control for atrial fibrillation with a beta blocker or calcium channel blocker, digoxin, anticoagulation in atrial fibrillation or flutter, diuretics for the fluid overload. And a serial echocardiography, we need every 2-3 years in a mild, every 1-2 years in a moderate, in a severe, in a 6 or 12-month basis. Infective endocarditis prophylaxis in a serious underlying dental procedure or other procedure indicated of high-risk procedure, patient with a prosthetic valve or history of infective endocarditis for dental and high-risk procedures. Key point in mitral regurgitations, asymptomatic severe, key points in management. Asymptomatic severe mitral regurgitation, usually no surgery. Asymptomatic severe mitral regurgitation, we say low ejection fraction surgery if mitral valve repair possible. Symptomatic severe mitral regurgitation is an indication for surgery. Left ventricular contractility is abnormal in severe mitral regurgitation, even if ejection fraction is normal. Ejection fraction less than normal, less than 60% in severe mitral regurgitation is an indication to operate. Echo estimation or echo and systolic dimensions more than of left ventricle more than 45 millimeter is an indication to operate. This means is the left ventricular dilatation. Afterload reduction provides symptomatic relief, but it's prevent progression except in established left ventricular dysfunctions have no benefit. In a simplified way, indication for mitral valve replacement in severe mitral regurgitation, any symptoms at rest or exercise repair if feasible. Repair. If it's not feasible, do a valve replacement. Asymptomatic patient, if ejection fraction less than 60%, even new onset atrial fibrillation, take a patient to the cardiac, operative for operation. Types of mitral valve prolapse. As we say, mitral valve prolapse is the commonest cause of the mitral regurgitation in Western nation. In a woman 20 to 50 years old, low blood pressure, they have orthostatic hypotension, palpitation, chest pain, atypical, usually atypical chest pain. If you remember, classical chest pain, ischemic chest pain is retrosternal chest pain or heaviness exacerbated by exertions or the exercise or stress relieved by rest or by glycerin trinitrate. If one or less than one is present, so it's atypical chest pain. Really, in mitral valve prolapse, the pain is atypical, not fulfill the criteria of ischemic chest pain. Mild systolic leak may be mid-systolic murmur too. In echocardiography, thickened redundant leaflet, anterior, posterior, or both of them, leaflet excursions, prolapse in left atrium, systole, redundant chordotendony, trivial or mild mitral regurgitation, as we said, is the commonest cause of mitral regurgitation. Little progression to the mitral regurgitation in a woman. Antibiotic for SBE, previously they give antibiotic, but now if it's indicated, history of infective endocarditis or interventions with the mitral valve prolapse. Mitral valve prolapse in a male really 40 to 70 years, maximatous and thickened mitral valve, significant leaflet prolapse, significant mitral regurgitation, progressive mitral regurgitation in contrary to the women. Complication, cord ruptures and atrial fibrillation. Endocarditis if mitral regurgitation present in a high-risk procedure, it must be given. Antibacterial prophylaxis to prevent bacterial endocarditis. Surgery of mitral regurgitation often required in this type. This is echo left parasternal view to see that the posterior mitral valve leaflet is regurgitated, prolapse in left atrium. This is a prolapse of this posterior mitral leaflet, and this is the anterior, it's not a prolapse, this is the doming in the left atrium. And this is anterior and posterior, this anterior, this is a prolapse there under with mitral regurgitation, a blood regurgitation in the left atrium from the left ventricle. And the chest x-ray of mitral valve, how different from the mitral stents, if you remember. This is the left ventricle enlargement, and the double contour here we can see, and the cardiomegaly is the very obvious. I mean, cardiothoracic ratio increased more than 50%. And compare the mitral stenosis and mitral regurgitation. This is chest X-ray. There is a cephalizations of the pulmonary hypertension. And cardiomegaly obvious, left ventricular enlargement and cardiomegaly. This is a mitral stenosis and then a double contour and splaying of left main bronchus, enlargement of left atrial appendage. This chest X-ray seen in the previous lecture. And this is mitral valve disease. This is calcium in the aortic nickel, this calcium in the mitral valve. Left atrial appendage enlargement, splaying of left main bronchus could be a combined mitral regurgitation and mitral stenosis. And the echocardiography in mitral valve regurgitation, this is the regurgitant volume in the left atrium. This is a mild regurgitant volume, and this is that the moderate and severe full of the left atrium. This is a left parasternal projection of view. Look, during systole, this blood ejected into from the left ventricle to the aorta, while during systole, this regurgitant volume. The blood, when directed to the probe, it look red. When directed away from the probe, it's look that the blue or sometimes orange. So this is a regurgitant volume, really full of the left atrium. This is a severe type, like this picture is a severe type of mitral regurgitation. This is an X-ray of the mitral valve disease, mainly is the mitral regurgitation. And this is a diagram to show that the regurgitant volume, this blood coming there during systole, and some of the regurgitant volume, sometimes very a considerable proportion of stroke volume is regurgitated back to the left atrium and then transmitted chronically to the right side heart. Thank you for the active participation. See you soon.